Good morning. My name is Dariusz Borys. I'm a professor of pathology orthopedic surgery at Loyola University Chicago. I'm going to talk about differential diagnosis of giant cell-rich lesions of bone. So I'm going to talk about most common benign and malignant giant cell lesions of bone. I will mostly focus on histopathology and new molecular findings in these lesions. Next talk by Robert Boutin will more focus on radiology. So I'm going to emphasize some most common benign giant cell rich lesions such as giant cell tumor, giant cell reparative granuloma, brown tumor, tenosynovial giant cell tumor, aneurysmal bone cyst, chondroblastoma, non-ossifying fibroma, and very shortly about a few malignant entities such as malignant giant cell tumor and giant cell rich osteosarcoma. So giant cell tumor of bone is locally aggressive and rarely metastasizing neoplasm composed of neoplastic mononuclear stromal cells admixed with macrophages and osteoclast-like giant cells. Mostly occur in skeletal mature patients, peak incidence between 20 and 45-year-old patients, and typically affects epiphysis of long bones, especially the distal femur, proximal tibia, distal radius, and proximal humerus. In rare cases, giant cell tumor may occur in skeletally immature patients, and the tumor is likely to be seen in the metaphysis. May give rise to pulmonary metastases that are clinically indolent in lungs. They may rarely undergo sarcomatous transformation, which can be caused spontaneous or secondary to radiation therapy, more common. And pathologic fracture occurs in about 10% of cases. This is how the lesion most of the time is discovered. X-ray picture showing lytic lesion in the left proximal tibia with no sclerosis in the margin and lesion extending into articular surface, consistent with giant cell tumor and highlighted with arrow. This is the gross picture of giant cell tumor filling the expanding and the central marrow space. Has soft, friable, tan red, and hemorrhagic appearance. There are hemorrhagic and blood-filled cystic spaces corresponding to aneurysmal bone cyst-like changes. This is a low-power view H&E slides of giant cell tumor, which shows multiple osteoclast-like giant cells intermixing with spindle mononuclear neoplastic cells. Higher power view show predominant giant cells with multiple nuclei and between spindle mononuclear neoplastic cells and hemorrhagic areas. And again, high power view showing multinucleated giant cell highlighted with yellow arrow and neoplastic mononuclear spindle cells circled with blue line. In rare cases, giant cell tumors may transfer into malignant form. In these cases, you will see increased atypia of stromal spindle cells and increased mitotic figures. So there will be a question how neoplastic spindle cells activate formation of osteoclast-like giant cells in the bone. This interesting article written by Dr. Brooks and colleagues published in Pathology tried to explain the mechanism. According to the paper, a mutation in the H3F3A gene, which is found in about 92% of giant cell tumors, induces the neoplastic spindle cells to drive reactive formation of osteoclast-like giant cells. This process results from spindle cell secretion of monocyte, chemoattractant protein, and macrophage colony stimulating factor, which promote monocytic cells recruitment and differentiation into preosteoclasts. Spindle cells also express receptor activator of NF-κB ligand, which acts on rank-expressing preosteoclasts to promote cell fusion. This cartoon maybe would better explain activation of monocytic cells and osteoclast-like giant cell formation. So neoplastic spindle cells recruit monocytic cells by secreting chemoattractants and activate receptor NF-κB ligand, RANKL, which acts on rank-expressing preosteoclasts to promote cell fusion and multinucleated giant cell formation. Understanding the role of the receptor activator of nuclear factor Kb ligand RANKL in the pathophysiology of giant cell tumor of bone has led to the use of denosumab, monoclonal antibody against RANKL, in this disease. It had important impact on treatment of giant cell tumors, especially in cases difficult to resect, recurrent, and metastatic. This finding were nicely described by Dr. Singh and colleagues in this Targets and Therapy journal. I would like to present this interesting case of 22-year-old patient with left knee pain for 3 months and no other symptoms to emphasize importance of molecular studies for clinical care. This slide on left show X-ray, which show metaphyseal epiphyseal expansile lesion, and on right MRI show predominantly cystic lesion. This histopathologic H&E slide shows blood-filled cystic space with fibrous septa composed of cellular proliferation of blunt fibroblasts and scattered multinucleated osteoclast-like giant cells. This higher power view shows a blood-filled pseudocystic space and scattered giant cells in the lumen of the cyst, which we sometimes call giant cells jumping into the lake. And this is one of the characteristic findings seen in aneurysmal bone cyst. This slide shows reactive woven bone rimmed by osteoblast in fibrous septa, which has been called blue bone and is also characteristic finding for aneurysmal bone cyst. Next slide shows area of more solid fibroblastic proliferation with crowding of osteoclast-like giant cells. This is higher power view, which shows dominating osteoclast-like giant cells and between spindle neoplastic cells. At this point, we were favoring diagnosis of aneurysmal bone cyst, ABC. However, the solid areas with giant cells were raising question for differential diagnosis of giant cell tumor with predominant ABC. To answer this question, we ordered additional molecular studies for histone 3.3 mutation H3F3A G34W, which is characteristic for giant cell tumor and was positive. It was a very challenging case because radiologic and histopathologic features were more suggestive of aneurysmal bone cyst. However, focal solid areas of the tumor with positive molecular studies for H3F3A G34W were consistent with giant cell tumor of bone with secondary predominant aneurysmal bone cyst. Another benign giant cell lesion of the bone is giant cell reparative granuloma. Giant cell reparative granuloma is benign, previously considered reactive process, but with new molecular findings is considered to be benign neoplasm with characteristic findings of granuloma-like aggregates of giant cells in fibrovascular stroma. Giant cell reparative granuloma was first described in the jaw in 1953 and was associated with rare hereditary condition known as cherubism and showed bilateral involvement of maxilla and mandible. GCRD is also commonly seen in small bones of hand and feet and is called giant cell lesion of small bones. As I mentioned before, giant cell reparative granuloma was considered as a reactive lesion. However, new studies show that some cases may harbor mutation in SH3BP2 exon 9. The findings were described by Littman and colleagues at the Musculoskeletal Tumor Society meeting. This is another interesting article written by B. Bezak and Aliquat in Pathology Journal. The article describes that some of the central giant cell lesions may harbor BRAF, GNS, and KRAS mutations. Giant cell reparative granuloma in most cases presents as pain and swelling of involved bone. Pathologic fractures may be seen, mostly involves bone of jaw, maxilla, and small bones of hand and foot. Was described in association with polyostic fibrodysplasia and Paget disease. This histopathologic section shows a giant cell reparative granuloma composed of spindle fibroblastic cells without atypia with osteoclast-like giant cells gathering around hemorrhagic areas. Compared to giant cell tumor, osteoclast-like giant cells are more dispersed in fibrostroma. This higher power view shows osteoclast-like giant cells gathering around hemorrhagic area and woven bone trabecule with osteoblastic rimming. Giant cell reparative granuloma may be difficult to distinguish based on histopathologic features from brown tumor or giant cell tumor. Clinical and radiological correlation is very important to distinguish between these entities. So let's talk about brown tumor. Brown tumor is also known as osteoitis fibrosa cystica or sometimes osteoclastoma. It's benign, fibrotic, erosive bony lesion caused by localized rapid osteoclastic turnover resulting from hyperparathyroidism. it is difficult based on the histopathologic findings to distinguish between brown tumor, giant cell reparative granuloma, or giant cell tumor. This cartoon shows the best correlation between parathyroid hormone and bone resorption. PTH stimulates bone resorption and release of calcium from bone. PTH activates osteoclast, and they activate osteoclast precursor and osteoclast formation. Osteoclasts cause resorption of bone, and in the case of hyperparathyroidism, they may form spaces in the bone which are filled with fibrohistiocytic cells resembling granulation tissue, what we actually see in brown tumor. This table shows laboratory data describing levels of calcium, parathyroid, vitamin D, and phosphate in patient in hyperparathyroidism. So we have primary parathyroidism, which is caused by parathyroid gland oversecretion of parathyroid hormone due to adenoma. In these cases, you will see increased calcium, increased or normal level of PTH, increased vitamin D, and decreased level of phosphate. The secondary parathyroidism is caused by disease stimulating parathyroid hormone overproduction. Most common causes are kidney failure or vitamin D deficiency. In these cases, you will see decreased or normal levels of calcium, increased parathyroid hormone, decreased vitamin D, and decreased or increased phosphate. And tertiary hyperparathyroidism is excess of production of parathyroid hormone, which can be caused by adenoma or cancer, parathyroid cancer, and it's not really responding to the therapeutic approach. And in these cases, you will see increased calcium, high skyrocketing levels of PTH, decreased vitamin D, and increased phosphate. So at this point, I would like to present this interesting case of 39-year-old female with recurrent nephrolithiasis and urinary tract infection who was admitted to hospital because of flank pain and obstructive renal stones. So when patient came, CT was performed to evaluate renal calculi. However, accidental finding, which I highlight with this red circle, was expansile mass in the right pelvis. Based on these findings, differential radiologic diagnoses were plasmacytoma, maybe metastasis, renal thyroid cancer, giant cell tumor, and in the differential also brown tumor aneurysmal bone cyst. So biopsy was performed, and this low power view show lesion with more cellular areas and less cellular hemorrhagic areas. This slide shows hyalinizing stroma with osteoclast-like giant cells. This again high power view shows hyalinized stroma with multiple multinuclear osteoclast-like giant cells. This higher power view shows other areas with spindle cell histiocytic cells without atypia, bone with osteoblastic rimming, and osteoclast-like giant cells. And another higher power view shows areas of histiocytic spindle cells with no atypia and brown hemosideroid deposition. The tumor was named as brown tumor due in some cases abundant hemosiderin deposition and brown color grossly. At this point with histopathologic findings, we were dealing with giant cell rich lesion, which was resembling in some areas giant cell tumor, in other areas giant cell reparative granuloma, which was raised possibility of brown tumor. I asked clinician about PTH and calcium level, and he said that they did not order them. So when they ordered them, parathyroid was really increased and calcium maybe slightly increased. So based on histopathological findings in correlation with laboratory findings, we diagnosed brown tumor secondary to hyperparathyroidism. So going back to another giant cell rich lesion, which is tinosynovial giant cell tumor, diffuse type, previously named as pigmented villonodular synovitis, which is more recognized. between orthopedic surgeons. So it's locally destructive fibrohistiocytic proliferation characterized by multiple villus and nodular synovial protrusion. And again, is it reactive? Is it neoplasm? So new molecular studies will show. So this is interesting article written by M. Bahmi at Aliquads and published in Current Therapies in Oncology. Authors describe that TGCT is associated with characteristic cytogenic abnormalities resulting in overexpression of colony-stimulating factor 1, CSF1. Because of that, systemic therapies targeting this receptor has potential for treatment of cases with local recurrence or not possible for resection. In the United States, recently, a new chemotherapeutic pexidartinib, which is CSF1R inhibitor, was approved by FDA and was used in patients who were not good candidates for surgery because of morbidity or functional limitations. So what we just discussed, new studies show that tenosynovial cell tumor is more neoplastic than reactive process. Mostly seen in young and middle-aged patients with peak incidence in the third and fourth decades. Most common location, knee joint, and less frequent, hip. This X-ray shows tenosynovial giant cell tumor in posterior knee joint with focal bone erosion, which is highlighted with red circle. And this is a gross picture of diffuse tenosynovial giant cell tumor and shows multiple villus and nodular synovial protrusion with brown discoloration due to hemosiderin deposition. This low power view shows tenosynovial giant cell tumor with lobular and diffuse growth pattern. This is higher power view of H&E slide of tenosynovial giant cell tumor, which shows alternating cellular and less cellular areas of proliferating mononuclear histiocytic cells. Another higher power view shows cellular areas of proliferating mononuclear histiocytic cells and scattered giant cells at the edges. This H&E slide shows accumulation of xanthomatous foamy macrophages, which may be seen in tenosynovial giant cell tumor. This H&E slide shows deposition of hemosiderin, highlighted with the circle, which you can see in tenosynovial giant cell tumor. So I just talked about diffuse type of tenosynovial giant cell tumor. There is also localized type, which may occur at any age, but usually between 30 and 50-year-old patients, predominantly affecting the digits of the hand. Less common may be seen in wrist, ankle, foot, or knee. Mostly present as painless swelling or mass and may gradually develop even for several years. X-ray film shows well-circumscribed soft tissue lesion at the site of the proximal interphalangeal joint. Arrow points to the small erosion of the base of the middle phalanx. This is low-power view of localized tenosynovial giant cell tumor and shows well-circumscribed, lobulate, and partially covered by fibrous capsule lesion. Higher power view shows proliferation of mononuclear histiocytic cells with blunt nuclei, pale cytoplasm, and scattered osteoclast-like giant cells, which shows similar histopathology to diffuse type. This picture shows area of stromal hyalinization in tenosynovial giant cell tumor localized type. Other benign giant cell-rich lesion I'm going to talk about is non-ossifying fibroma. NOF is intracortical proliferation of fibrous tissue and histiocytes. There is still question if this is neoplastic or non-neoplastic lesion. However, new molecular findings are more suggestive of neoplastic background. This is an interesting article written by Dr. Judith Beauvais at Aliquads in Journal of Pathology. Article indicate their findings that non-ossifying fibroma is a RAS-MAPK mutation-driven neoplasm. However, their data suggest that only a subset of cells in the lesion contain the mutation. A second cell population consisting of histiocytes and osteoclast-like giant cells appear to be reactive. So based on molecular findings, NOF has neoplastic potential. NOF may be solitary or multiple with equal frequency. About 30 to 40% of children have one or multiple non-ossifying fibromas of bone. Most cases occur in distal femur, distal and proximal tibia. They have high predisposition to fracture, especially when they confine more than 50% of the bone. In these cases, they become painful because of the fracture, and how these lesions are discovered in most cases. This X-ray film shows NOF as eccentric, well-defined, lobulated lithtic lesion, sclerotic border centered within the metaphyseal cortex of proximal tibia, highlighted with red arrow. So this is a low-power view of non-ossifying fibroma showing proliferation of blunt, spindle-shaped cells arranged in whorled, storiform growth pattern with variable number of scattered multinucleated osteoclast-like giant cells. Higher power view shows blunt, spindle-shaped cells with scattered multinucleated osteoclast-like giant cells, characteristic for non-ossifying fibroma. In NOF, treatment is usually aimed to the prevention of fracture. As a general rule, lesions that occupy more than 50% of the total diameter of the bone are considered at high risk for fracture and therefore should be treated. Lesions are known to regress spontaneously, and differential diagnosis, of course, giant cell tumor and desmoplastic fibroma. NOF may be associated with other syndromes such as Jaffe-Campanacci syndrome, characterized by congenital syndrome of multiple non-ossifying fibromas and Coffey-Olé pigmentation, mental retardation. Other syndromes NOF may be associated with is neurofibromatosis and, of course, familiar multifocal NOF. Another benign primary bone lesion is aneurysmal bone cyst. So thought to be reactive or maybe neoplastic change secondary to vascular malformation, and there is documented association with trauma or fracture. So as I mentioned previously, it was always question about origin of the aneurysmal bone cyst. Is it reactive or neoplastic process? According to this paper written by A. Oliveira et aliquots and published in Tumorigenesis and Neoplastic Progression, primary aneurysmal bone cysts demonstrate clonal chromosome band 17pq translocation that place USP6 oncogene under regulatory influence of the highly active CDH11 promoter. So again, looks like ABC has more neoplastic potential than we thought previously. ABC affects all age groups, but generally occurs during the first 2 decades of life, with median age approximately 13-year-old patients, usually arise in the metaphysis of long bones, especially the femur, tibia, and humerus. About 30 to 50% of cases are associated with other pathologic entities such as giant cell tumor, chondroblastoma, osteoblastoma, NOF, and osteosarcoma. This X-ray show aneurysmal bone cyst presenting as eccentric expansile lesion with well-defined margins affecting medullary cavity of metaphysis of distal femur, which is highlighted with red arrow. This gross picture shows well-defined sponge-like mass composed of multiple blood-filled spaces separated by thin tan white septa. This H&E slide shows aneurysmal bone cyst composed of cystic spaces separated by fibrous septa composed of dense proliferation of blunt fibroblastic cells with scattered multinucleated osteoclast-like giant cells. This H&E slide shows pseudocystic space with fibrous septa composed of dense proliferation of blunt fibroblasts with scattered multinucleated osteoclast-type giant cells and reactive woven bone ringed by osteoblasts. This H&E slide shows lumen of pseudocyst filled with blood and multinucleated-like giant cells, and they look like jumping into the lake. This slide shows more solid areas of fibroblastic proliferation and pseudocystic spaces filled with blood. Spindle cells should not show any atypical mitotic figures. If they do, you should consider more aggressive neoplasm, such as telangiectatic osteosarcoma. This slide shows more cellular and solid area of ABC with scattered multinucleated osteoclast-like giant cells, which may be confused with giant cell tumor. In summary, it's important to remember that aneurysmal bone cysts may be secondary finding in any other tumors such as giant cell tumor, chondroblastoma, osteoblastoma, NOF, or osteosarcoma, and careful sampling of the tumor is important to rule out precursor lesions. A solid variant of ABC was described and can be sometimes difficult and challenging to distinguish from giant cell tumor or the other bone lesions. In these cases, new molecular finding as positive USP6 and CDH11 would be very helpful. Therapy of adenosine bone cysts mostly is excision, curettage, cryotherapy, and can be a variable recurrence. Another benign cartilaginous giant cell-rich lesion is chondroblastoma. Chondroblastoma is most common in adolescent age group. Most common location is epiphyseal in the bone. Most common bones involved are distal femur, proximal tibia. Commonly has secondary ABC-like changes. And in histology, there are triad of findings of expansile sheets of chondroblast, pink chondroid matrix, and lace-like calcifications, which I'm going to talk next. This X-ray of chondroblastoma shows eccentrically placed, well-circumscribed, sharply demarcated epiphyseal lytic lesion with thin rim of sclerosis and is highlighted with red arrow. Low power view H&E slide of chondroblastoma shows proliferation of mononuclear chondroblasts with fair eosinophilic cytoplasm and scattered multinucleated osteoclast-like giant cells. High power view shows proliferation of ovoid to polygonal chondroblasts with small singular grooved nuclei and eosinophilic cytoplasm. There are scattered oculus-type giant cells, mostly grouping in areas of matrix production and hemorrhage. This higher power view shows poorly formed cartilage with areas of calcification forming chicken wire pattern around single cells. So no specific but characteristic stainings can be vimentin S100 and neuron-specific enolase. Main differential diagnosis, of course, is giant cell tumor and clear cell chondrosarcoma. New molecular studies described by H. Akalplo and colleagues in histology show that some of the chondroblastomas may express DOG1 stain, which may be useful in some cases to distinguish from giant cell tumor or chondromyxoid fibroma cases. This is an interesting paper written by Dr. Behaji and colleagues and describes new molecular findings in chondroblastoma. According to the paper, about 95% of chondroblastoma harbor mutation in H3F3B in region K36M, and comparison, about 92% of giant cell tumor harbor mutation in H3F3 in the region 34W, and the mutations were restricted to the stromal cell population and not detected in osteoclasts or their precursors. This figure from the paper highlights number of cases of giant cell tumor with mutation H3F3A, region G34W, yellow column, and in comparison cases of chondroblastoma with mutation H3F3B, region K36M, green column. There are some maybe less common malignant tumors with giant cell rich component. I shortly talked about malignant giant cell tumor, and another is giant cell rich osteosarcoma. So giant cell rich osteosarcoma is a rare histological variant of conventional osteosarcoma with rich giant cell component, of course, commonly presenting in long bones of appendicular skeleton, rarely may be seen in mandible. Its radiologic and histologic resemblance to giant cell tumor can pose great diagnostic challenge. This is a low power view showing proliferation of atypical pleomorphic cells with scattered giant cells. This higher power view H&E slide show stromal neoplastic cells producing immature osteoid and scattered around osteoclast-like giant cells. Findings are consistent with giant cell rich osteosarcoma. It was a short review of the most common benign and malignant giant cell rich lesions. In summary, we should remember that not all neoplasms with giant cell rich component are giant cell tumor. radiologic pathology correlation is masked to differentiate a giant cell tumor from another giant cell rich lesions. Giant cell herpatic granuloma, tenosynovial giant cell tumor, ABC, NOF, previously described as reactive processes with molecular analysis, became neoplastic lesions with potential for targeted therapy. Thank you for joining me today, and now I'm ready for your questions.